And now I would like to introduce Lynnette, our first speaker. We'll have two speakers today, and then we'll finish up with questions and answers. Lynnette Reville received a bachelor's degree in audiology from the University of South Florida and a master's degree in audiology from the University of Central Florida. She earned her certificate from the American Speech Language Hearing Association. She has more than 28 years of experience as an audiologist, and she will now give an overview of hearing and hearing loss.
Hello. Do you have the slides on, please?
Sure, I can pull it up for you.
Thank you. Second slide, please. The ear itself is mainly a transfer system. The outer ear is comprised of the parts that you see, the ear canal, up to the eardrum. The middle ear is comprised of 3 bones, 2 muscles, and 5 ligaments, which all fit on a pin. The inner ear is divided in half. Half is vestibular or balance, the other half is auditory, and it is responsible for sending the signals up to the brain to be decoded. So when sound hits the eardrum, it moves 3 bones. This is mechanical energy. When the bones impinge on the fluid in the inner ear, it becomes hydraulic energy. The fluid in the inner ear moves, excites hair cells in the inner ear. Now it becomes chemical electrical energy, which synapses up to the brain for the brain to understand. Second slide, please. Thank you. The outer ear can have difficulties sometimes if a person has been swimming in a lake and there might be some bacteria in the water. This is called like a swimmer's ear, and the water gets trapped possibly behind some wax that's in the ear, and it's extremely painful. But generally, this type of an outer ear infection does not cause hearing loss. The middle ear is an air-filled space, and it keeps the air fresh, or the air on both sides of the eardrum equal by the eustachian tube opening up or your ears popping. If the eustachian tube doesn't open often enough, the air that's in the middle ear can be absorbed by the mucus lining, which creates a vacuum, and then the middle ear lining will start to allow fluid to escape, mucus, which can cause fluid behind the eardrum, or which can be infected or non-infected depending on if there's a germ introduced, or possibly if there's a hole in the eardrum, or possibly if the bones in the middle ear are not working together well. Those can cause different difficulties in the transmission of sound to the nerve. The nerve would still be fine, but the middle ear isn't able to function properly. The inner ear, where the hair cells are, that can be damaged by certain drugs that are toxic to the ear itself. Certain strands of antibiotics, or noise, different types of noise can cause destruction of the hair cells, and so there'll be spots within the nerve that are unable to transmit sound to the brain. You can also have a mix of a middle ear problem and an inner ear problem, which would be a mixed loss. Next slide, please. With the outer ear, like swimmer's ear, a doctor is able to prescribe a medication of an antibiotic or a topical type treatment, and that can soothe and ease the pain and cause the swelling to go down. With the middle ear, if antibiotics aren't working to take care of the fluid that's possibly behind the eardrum, a physician's able to do a tube placement, makes a small incision into the eardrum, suctions out the fluid, and then leaves a tube in place in the eardrum for the eustachian tube to help regain its function, remember what it's supposed to do. If it's something where the bones aren't working well together, then the doctor sometimes is able to help reconstruct the way the bones are supposed to be articulating with each other, or the use of a prosthesis in place of a bone if it has disintegrated in some way or form. With the inner ear, at this point in time, science is not able to rejuvenate nerve cells or hair cells. So the general treatment for an inner ear problem would be the use of hearing aids for amplification. Next slide. And that pretty much is an overview of the ear and how it works. Back to you.
Thank you. All right, let's get back to our next speaker is Sally. She graduated from Longwood University with a Bachelor of Science in Communication Sciences and Disorders and earned a Master of Science in Speech Language Pathology. She's worked at VCU Health CMH for 2 years and has experience with both pediatric and adult populations. She will now give an overview of speech language pathology.
Thank you, Christy. I'm really excited about this and hope y'all learn a lot. I'm going to share my screen with you so that you can see. So like I said, I really just want to give an overview of what speech language pathology is and the populations that we work with. We have a very broad scope of practice, so I don't have time to dive into everything, but we do have time for questions at the end. So if you have any questions, please don't hesitate to ask. So I wanted to start off with some quick facts. In the US, communication disorders has a prevalence of about 5 to 10%, and approximately 5% of children will have a noticeable speech disorder by 1st grade. More than 3 million people in America stutter. Approximately 7% of Americans have some type of language impairment. Around 1 million people in the US have aphasia, which I'll go into a little bit more about later. And it's estimated that 1 in 25 people will experience dysphagia or trouble swallowing within a given year. So like I said, we have a very broad scope of practice. We treat a variety of disorders and illnesses across the lifespan. So from birth all the way into the geriatric population, we work with everybody. So we have 9 major areas that we do. Cognition, which includes memory, problem solving, attention, language, motor speech, fluency, which you might also recognize as stuttering, hearing, alternative or augmentative communication, social skills, which you also might see referred to as pragmatic skills, voice and voice disorders, and even swallowing. Some common medical diagnoses that we work with include respiratory illnesses like COPD, traumatic brain injury, autism, cerebral palsy, stroke patients, head and neck cancer, patients with genetic syndromes, dementia, and Parkinson's disease. This is not, all medical diagnoses that we work with. We work with even more. These are just more of some of the common ones that we see. So I wanted to go into specifics for adult speech language pathology. Like I mentioned earlier, we work with the lifespan, but based on the audience that we typically have at our programs, I wanted to focus more on what we can do with adult patients. So some common diagnoses that we see in adults are dysphagia. Like I said, that's just trouble swallowing. Dysarthria, which is slurring of speech. Apraxia, which is a motor speech disorder where the brain has difficulty coordinating motor movements for speech production. Aphasia, which is a language disorder. This can be expressive, receptive, or both. So the patient with aphasia may have difficulty with word retrieval, thinking about what they want to say. They also might have difficulty understanding language or comprehending what is said to them. But there are also times when they have a mixture of both, so receptive and expressive aphasia. Cognitive communication disorders, or dysphonia or aphonia. So dysphonia is just a voice disorder, someone who might have vocal nodules, vocal paralysis, or any trauma to the vocal folds, maybe after a surgery. And then also aphonia, which is a lack of voicing. So maybe someone who's had a laryngectomy. I'll go over some treatment methods that we utilize. We have different strengthening exercises that we can do if there is weakness with trouble swallowing or with any of the oral motor structures. There are some exercises that we can do to strengthen those muscles. We have compensatory strategies. So if you are a dysphagia patient, we might recommend some positioning strategies for you. If you're having trouble with memory, we might make some recommendations maybe to write things down or keeping a calendar to help you stay organized. If you do have dysphagia or trouble swallowing, we might make some recommendations for some changes to your diet. So we might recommend, if you're having trouble chewing, that you consume a softer textured diet. If you're having trouble swallowing, where liquid may be going into your lungs called aspiration, we would recommend maybe some thickened liquids to help alleviate that risk. So I want to keep y'all as engaged as possible. So I wanted you to try one of our swallowing exercises that we have. This is called the Masako maneuver. It also might be referred to as the tongue hold maneuver. And if you're not comfortable with it, you don't have to, but it's one of my favorite exercises. So I'm going to have you stick your tongue out as far as you can and gently hold it between your teeth. And while you're gently holding it between your teeth, I'm going to have you swallow your saliva. So it can be a very difficult exercise for a lot of people to get used to. But this is just one of our swallowing exercises to strengthen the pharyngeal phase of swallowing when the food is flowing through your throat, to help your tongue move further back in your mouth, to squeeze the food down into your stomach rather than maybe going into your lungs. So what can you expect with an evaluation with a speech language pathologist? So first I want to mention that you do have to have a referral from your physician. So if you're having any difficulty, please reach out to them and have them send an order over. So an evaluation just includes a lot of questions, interview. We really want to know what's going on, how it's impacting your day-to-day life. And then we will give a standardized assessment. So this helps us gather a baseline of where you're at now, so we can compare that to your progress later on in treatment. If you're coming for a dysphagia evaluation, we'll have some snacks available for you. So we'll have you eat and drink some to see how you're swallowing, see how you're able to chew. We'll do an oral mechanism exam, so we'll see how the oral motor structures are working and if there's any weakness or decreased coordination between your lips and your tongue and things like that. Then we'll also provide some education for you. So what you can be working on at home, compensatory strategies, prognosis, how you can compensate for what's going on. And then from your evaluation, we'll develop a plan of care with goals to get you to where you want to be and help improve your quality of life. And typically, we see patients 1 to 2 times a week, depending on their diagnosis. And our treatments can last 1 month, 2 months, or even longer, depending on the patient. If you're coming for a swallowing evaluation as an outpatient, we may recommend some further imaging to see how things are flowing from your mouth through your throat and into your stomach. So you'll see a picture here of an x-ray. We may request that you go for what's called a modified barium swallow study. We would have to get a new order from your doctor for you to go over to radiology at the hospital, where we, like I said, would do some further imaging to determine if anything is going into your lungs or to help determine which exercises are going to be most beneficial for you. So what do we have to offer here at CMH? We have 3 full-time speech therapists in acute care at the hospital, home health, and outpatient as well. We have 2 different types of swallow studies that we can do, a fiber optic endoscopic evaluation of swallowing, or like I mentioned, a modified barium swallow study. Currently, our fiber optic endoscopic evaluation of swallowing is only available for our inpatients at the hospital, but we are working to have that available to our outpatients as well. We are all trained in neuromuscular electrical stimulation, just another treatment method for strengthening oral motor muscles, as well as swallowing muscles. And then we also offer the Lee Silverman voice treatment program for maybe patients with Parkinson's or with other voice disorders. We're also working collaboratively, since we are right next door to our cancer center, we're working to develop a program for our breast cancer patients who may have cognitive deficits after they go through their treatment. So these are my sources for today. And then this is contact information for our outpatient center. If you have any questions about getting a referral, if you're interested in a referral, or if you have any questions about any of the information today that you might think of later, please don't hesitate to reach out. And then that is all I have. I believe, Christy, it's time for some questions.
Yes, thank you both. That was very informative. If you all have any questions, you can either type them in the chat or you can just unmute your microphones and ask. Well, Sally, I have a question for you. Do you see many patients with myasthenia gravis?
We have seen patients with that diagnosis. You know, I wouldn't say it's rare, but we don't see it very commonly, but we can work with those patients.
Are you able to see much success in helping their swallowing issues?
Short term, yes. Long term, we may have to help them prepare, should they need a peg tube down the road. But we can kind of help improve their quality of life in the meantime.
Okay, thank you. Well, I don't see any other questions. Again, if you guys have any follow-up questions, feel free to reach out and we will do our best to get you in touch with the experts. And look for all the contact and the presentation on our Facebook page and on our website under core programs. Thank you all so much. We'll see you next month.
Thank you, Christy.